Okay. Hi, I'm Suzanne Dickinson with the EVMS Ultrasound Education Department, and today we're going to go over some MSK and we're going to cover the shoulder. All right, for today's session objectives, we're going to, of course, introduce some of the clinical applications as well as going over machine setup and some of the options, and patient setup and acoustic windows, as well as the sonographic signature of the shoulder tendons that you're going to be looking at and the acquisition of those images. We're going to go over some pearls and pitfalls and an Spi Snapshot, and finally the scanning cards that you'll be able to see on Blackboard. So applications for focused or point of care ultrasound for the shoulder, you might be looking for tendon tears and subluxation, particularly subluxation of the biceps tendon, tenosynovitis, impingement, and bursitis, as you remember that you have the SASD bursa overlying the shoulder. To do this, you have to consider the relational anatomy of the bone, the shoulder girdle specifically, and the muscles, the deltoid and biceps brachii. Also the tendons of the rotator cuff and the long head tendon of the biceps. You'll also need to consider the bursa and the synovial sheaths. Remember that the biceps tendon is going to be covered in a synovial sheath, and the SASD bursa overlies the glenoacromial joint and can reach all the way over to the coracoid area as well. You also want to be familiar with articular cartilage and not mistake that for any kind of pathology. So our machine and patient setup, we're going to be entering the patient information as instructed on Blackboard. We are going to choose our linear probe, and we are going to select MSK or superficial, and we're going to use our depth, gain, and focal zone at default until we begin scanning, and our TGCs align centrally, and adjust them as needed when we're scanning. So let's take a look at the machine, and we can go over those items. So when we were doing patient, in this field you're going to want to put what we are covering. In this case it'll be shoulder. And this will be whatever class that you are in. Let's see, for instance. And then we're going to hit OK with our set button. And you see that we're already in a linear probe. I'm going to select exam. Now we can choose small parts, and in this case we do have an MSK selection. So you'll want to choose MSK if that choice is given to you. And now we're set up to go. Now patient position is going to vary on what you're trying to get to. So normally we would want to have the patient seated or in an upright position on the stretcher. You can also just sit them on a stool that moves, you can reposition them in that stool. The reason why you have them in a stool or sitting up is because you're going to have to do some of this dynamically. You're going to have to actually move that shoulder or the joint in such a way as to expose the tendon that you're trying to see. So for instance, you may have a neutral position that you're going to keep the patient in when you're trying to go for the biceps tendon, or you may have to do a lateral rotation of the shoulder in order to be able to expose the subscapularis muscle, and you may do a modified cras. Now full cras would be that instead of the hand being in their hip pocket, it would lay all the way across their back. that can be uncomfortable for some patients. And so a modified CRAS is the preferred place to start with the supraspinatus. Your probe marker by convention, your probe marker is going to point in long axis proximally. And then transverse axis will just be your 90-degree rotation counterclockwise to that position if you need to look at the tendon in both positions. And as usual in MSK, you want to use your heel toe, your sweep fan, and your pivot. So your pivot maybe to straighten out and get on that nice long axis of the tendon that you're looking at. Your sweep fan and heel toe in order to align your probe perpendicular so that you avoid anisotropy. So let's talk just for a moment about the deltoid, and then we're going to move to the machine and show you how we can acquire those images. So the deltoid, as you see, is going to overlie the entire rotator cuff muscles and tendons, or rather the tendons, and the biceps tendon as it overlies that glenohumeral joint. So the black bar on there is showing you approximately where the probe marker is for this particular image. And so you can see the muscle tissue overlying the humerus in this case. And you should see the deltoid in every image because it's always going to have some of its fibers there. Now sometimes those fibers you'll cut through them in a transverse or oblique line, and sometimes you may cut over them on a long axis line. And if you have already familiarized yourself with the general MSK, you'll know the differences of how the muscle will look like when you're cutting through it in transverse and long. So let's go to the machine and our patient and have a look at the deltoid. So what you'll want to do with your patient is you're going to want their hand to be in a neutral position, which means the palm is going to be up, and you may make some minor adjustments inward and outward depending on the patient's shoulder. So and that's going to largely depend on the size of the shoulder. So we have a relatively smaller shoulder here, so we might have to make some adjustments to line up that whatever that we're looking at. But in just looking at the deltoid, just going to put a little gel on my probe. And we know the deltoid is making that cap. So anywhere that I put the probe, I should be able to see. Let me go to the screen, please. Oh, the ultrasound. There we go. Perfect. All right. So as we look at this shoulder, just going to turn down my gains a little bit here. And I'll put on my cursor. We can see the overlying tissue of the deltoid. Now this deltoid is more in a transverse cut. If I turned long on its fibers, you can see the typical long axis appearance of the deltoid here. All right, let's take a look at our biceps tendon. We can go back to our slide. So if we take a look at where the biceps tendon is, let's remember that it runs along the bicipital groove, and it will attach to the labrum of the glenohumeral, or the glenoid fossa, right? And so in this case, to look at that long head, we're going to want it to be in neutral position. So here's essentially the same image, except that on the left image, we're seeing the biceps tendon in transverse, lying in the bicipital groove between the greater and the lesser tubercle. When we turn long axis, keeping our probe right in the center on that groove, we can stretch out the biceps tendon, and we can even follow it all the way down to the muscle, the biceps brachii muscle. So let's take a look at that on our patient. Now again, I'm going to be using transverse neutral position. I'm going to go right onto the patient's shoulder. And if we look on our screen, in this case, I'm going to have to bring her arm in a little bit in order to rotate that shoulder into a position where I can be straight on to the biceps tendon. So, give me just a second here. All right, so our biceps tendon is going to be right in here. Now I can make that biceps tendon disappear. So that's that. You've got to be cautious of anisotropy at all times. All I have to do is do a little sweep movement, and there is that nice bright tendon right in the bicipital groove. And we have our lesser tubercle on this side, and we have the greater tubercle on this side. In most people, this lesser will have a more peaked appearance to it. And you can also identify the lesser because when we move on to our next tendon, you can actually see the hint of it showing up on this side, medial to the lesser tubercle. So let's take a look at what that tendon might. Oh, hold on just a moment. Let me come back to this biceps because I need to show you this in long axis as well. I'm going to follow this first in transverse axis as we go down the arm, keeping my probe on it, adjusting for anisotropy, and we can see it join into the muscle, the biceps muscle. If I take it back up, adjusting as I go for anisotropy, I can follow this all the way up. I'm going to turn my probe long axis. Remember that my probe marker is going to point towards the patient's head. And as I turn on that tendon, we see that bright fibular pattern of the tendon. We see a thickening up in here, but remember that there is a synovial sheath around this tendon as well as the transverse humeral ligament. But we can follow that fibular pattern all the way down until it starts to join with the biceps muscle. Note that the deltoid maintained its position anterior or superficial to these structures, but that you can see the tendon fibers beautifully as we follow back up into that bicipital groove. Once it crosses over, you can no longer follow it in because too many bony structures will be in your way to be able to see it down over here. Okay, let's move on to our next tendon. Back to our slides. So the subscapularis is going to be part of the rotator cuff, as you know, and it's going to lie on that anterior surface of the scapula, and it's going to attach to the lesser tubercle. So in order for us to see this, because it lies underneath the coracoid process, we have to do a lateral rotation. And when we do the lateral rotation, it's going to reveal the tendon to us. We'll still see that overlying deltoid, but now you'll be able to watch this in real time as the tendon slides out. But you also want to watch it sliding out of that from underneath the coracoid, and you're going to want to go back and forth a little bit to make sure that it's not impinged in any way. And there's another reason why we want to do that movement, is to watch to see if the biceps tendon stays where it's supposed to stay, because in subluxation it can actually pop out on this maneuver and will show up over top of the lesser tubercle. And that would be a dynamic way of showing a diagnosis of biceps tendon subluxation. And while you're watching the subscapularis coming out from underneath the coracoid, you're looking for any sort of impingement or some evidence of bursitis in that area. So let's go back to our patient and take a look at those images. We're going to return to our home base. I'm going to just come in just a little bit like that. Okay. And here is our biceps tendon. And as I pointed out to you earlier, we have our lesser tubercle here, and we already are starting to get a hint of the subscapularis right here. So if I move more medial on my patient, I begin to notice this bony structure here, because that is the coracoid. And now we can see that this indeed was the subscapularis tendon. But we have a problem, right? We have an issue of anisotropy, so we cannot see the tendon fibers very well, so we need to pull this tendon out from underneath the coracoid. And while doing that, we're going to look in this area for any kind of impingement or evidence of bursitis. So I want you just to bring your arm straight out, and you can see the tendon slide easily out from underneath the coracoid, and no evidence of fluid, as I have the patient moving in and then back out to lateral rotation. See right there? And once we do that, we compensate for the anisotropy, and we can see the tendon fibers very well. If we follow the tendon all the way out to the lesser tubercle, we can see its attachment over the lesser tubercle here. And importantly, while she's in that lateral position, the biceps tendon is still sitting in the bicipital groove. So no subluxation, and there was no impingement or bursitis. And we're able to evaluate this tendon as we scan and sweep through it. Okay? And that would be your subscapularis. Let's go back to our slides and talk about our next tendon. So the supraspinatus is going to lie in that supraspinous fossa of the scapula, and it's going to move over under the acromion and over the head of the humerus to attach on the greater tubercle. But we can't get to it very well if we don't move the patient's arm again. And in this case, we're going to use the modified CRAS. Now, this is the best place to also evaluate the SASD bursa, as it's a rather large bursa that lies between the deltoid and the supraspinatus. And in this example, you can see on the left a normal supraspinatus attached to the greater tubercle. Now, to the right, directly across on the left, you can see a to the right rather, you can see bursitis. So if you look back to the image on the left, you see a hypoechogenic line crossing over top of that tendon. That is a normal bursa. And you can see the abnormal one, how it's filling in and actually going down over the greater tubercle, because it's going to extend down over the shoulder. And in the image on the bottom, it's just more centralized over that SASD bursa so that you can see it overlying the tendon. All right, let's see what this is going to look like on our patient. Now in this case, we're going to have to get the patient to sit forward a little bit so that she can extend and internally rotate her arm so that we can pull that tendon out from underneath the acromion. And just as an example, I'm going to have her put her arm in neutral position so that first you can see how that tendon is hiding underneath the acromion. So right here is the acromion, and here is my tendon. And I can't fully evaluate it in this position, although I could, if I abducted her arm, check to make sure that it slid underneath well, but I can't see all the structures that I want to see. And so this is where I'm going to have her extend and internally rotate, and you can see immediately how much more of that tendon became exposed, and how now we can actually see the bursa overriding it. So we have head of the humerus here, we have the greater tubercle here, Now this darkened area in here, I haven't talked about the articular cartilage except to mention it briefly. If I freeze my image here and show you the neck is here, you can see this hypoechoic articular cartilage here. You don't want to mistake that for any kind of tear. Let me go live again and go right over that greater tubercle and really get perpendicular to those fibers. Now it's very important to sweep all the way through the supraspinatus, looking for any sort of changes in that nice fibular pattern. And what's also important is you want to be able to turn on it into a transverse plane. So you're turning 90 degrees from the position of your probe to stretch out and make it look, sometimes this is described as looking at a tire around a wheel. Because here's our head of the humerus, here's our tendon in transverse. I'm going to move anteriorly on her shoulder until I can see the biceps tendon again. And this is called the interval. Most tears occur on this anterior portion of the supraspinatus. So you want to fully evaluate this area, going completely over it, looking for any kind of evidence of a tear. And in this case, you might even want to let the shoulder come forward ever slightly so that you can bring that biceps tendon to the center and be able to evaluate both sides of the interval, the supraspinatus over here, the supraspinatus over here and the subscapularis over here. And you can evaluate that area. Okay? That is the supraspinatus. Let's go back to our slide. Take my glove off for a moment. Okay. So, labeling for this session is going to be just as instructed on Blackboard, and as I showed you briefly, you're going to be putting in shoulder, you may be putting in SST for supraspinatus, and under first name you're going to be putting in the name of the class that you're in. Be sure that when you label that you must include your name and ID and the area of interest. So for the supraspinatus, a common way to abbreviate it is SST. So writing long, right SST if that's doing the right shoulder, or left SST doing the left shoulder. And be sure that when you label the anatomy as instructed in Blackboard, that you don't let any of your labels obscure the relevant anatomy. So in this case, if you have to label the head and the greater tubercle, be sure that it's in the black portion and not obscuring any important anatomy. And if you have to label the deltoid, put it a little off to the side and use an arrow to label it. Okay, some pearls and pitfalls. Remember again, don't start scanning until you have put in your patient information and selected your preset. Preferably set your preset for MSK if available, otherwise you can use superficial. Always be aware of anisotropy. This is really the most critical part of artifact in MSK. Make sure that you set your gains that the muscle tissue is at that lower mid-gray and the tendons show their bright fibular pattern. And don't forget to set the focal zone at the posterior aspect of the tendon of interest. Now I want to talk about our SPI snapshot. You may have not noticed this adjustment that you can make on your machine, but in MSK it can be kind of important, and we'll go to the machine and I'll show you how you can control this in a moment. But what is dynamic range and how can we use that to optimize the image? So dynamic range is really the range of amplitudes from the largest to the smallest that the ultrasound machine detects, and this is expressed in decibels on the machine, and there is an area where you can look at it on your screen, and I will show that to you. When we use compression, or the machine is using compression behind the scene, it's smoothing out those signals that the machine listens to, and that will have a net effect on how many grays are showing up on your screen. So let's take a look. So what does that represent in B mode? It means that if I turn my dynamic range very high, it's going to give me more grays in the image, less variation between one shade of gray to the other. But if I set my dynamic range very low, it's going to show fewer grays and a lot more range in between those grays. More of a black and white image as opposed to all the intervening shades of gray. For MSK, and this can be depth dependent, and it can also be thickness of tendon dependent, a dynamic range between 90 and 105 decibels better detects that fibular pattern of the nerves and the tendons. And if you notice in the image above, the image on the left is set at a dynamic range of 240, which means we get a much softer appearance to the image, but really too soft for us to distinguish the structures that we need to see. And if we set it too low, it's by far too contrasty, for a better word. You'll see that there's very little variation in the grays. It's very black and white. And again, certain structures can be missed if you go too low. So where's our Goldilocks zone? Well, somewhere between that 90 to 105. You can push it a little bit higher as needed in certain instances. Again, it's depth dependent, but we can see how we can see those fibular patterns beautifully on this tendon when we use the appropriate dynamic range. So let's go to the mind ray now so that you can see where I'm adjusting that. If we look up at the screen, this needs to be moved. You will notice right here that you can move and change these menus. If this lit up downward caret, if I select that, you'll notice the menu changes. If I select it again, I get even more of the menu. And here is our dynamic range. The images that you saw in this session were at 103. And I can change that to whatever I want. Simply by using the up and down arrows, I can go much further up, all the way up to 240. And if I kept pressing, it'll come back around to its lowest setting of 30. But we want to be, again, somewhere around 100. And if you look up on the screen over here, here's your dynamic range. And this is where it'll display for you on the mind ray. Okay. So, next I just want to talk to you briefly about the scanning cards that will help you through this session as you move towards your badging. And you can find them on Blackboard, and we do have your anterior shoulder and a few others, but here's just an example of the 3. Now I hope this was an informative episode for you, or session for you, and thank you for joining us on UltraSoundbytes. I hope it will help you find those tendons that you're looking for, and have a little fun doing it too.